You are now listening to MedEd Talks Rheumatology, a Vindico Medical Education production. The following podcast series is titled Year in Review, Uncontrolled Gout, Comprehensive Updates on the Latest Management Strategies, a rheumatology podcast series, and is supported by an educational grant from Horizon. To earn CME credit, log into mededtalks.com and search Uncontrolled Gout, Comprehensive Updates on the Latest Management Strategies. Or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives. Now, here's your host, Dr. Michael Pillinger.
Hello, and welcome to our podcast on updates on burden and complications of uncontrolled gout. I'm your host, Dr. Michael Pillinger. I'm a professor of medicine at New York University Grossman School of Medicine here in New York. I'm joined today by my exceptional colleagues, Dr. Grewal and Khanna. Dr. Suneet Grewal is a rheumatologist at the East Bay Rheumatology Medical Group in San Leandro, California. And Dr. Puja Khanna is a professor in the Department of Medicine, Division of Rheumatology at the University of Michigan in Ann Arbor. Today, we're going to focus on some of the recent presentations from ACR Convergence, EULAR Congress, and ASN Kidney Week. In this episode, we'll be focusing on gout disease burden, common comorbidities, and complications of uncontrolled gout. And we've selected about 5 abstracts that we think are pretty interesting for you. The first one is a presentation by Mithal et al. At ACR examining VTE, venous thromboembolism, in patients with gout. So, Dr. Grewal, could you tell me a little bit about the study and share some thoughts about this interesting and potential association of gout and thromboembolism?
Yeah, thank you, Dr. Pillinger. So this was quite interesting. This has been looked at a few times in the past, but we've had this kind of curiosity over time about the relationship between hyperuricemia and gout with venous thromboembolisms. And so the abstract here presented had a key takeaway of the fact that 1 out of 10 hospitalizations in people with gout had a concomitant diagnosis of VTE, whereas in the non-gout population, the prevalence was 1 out of 12 patients. And so there was this heightened risk found in patients with gout for VTE. And so, this is interesting because there has been data preceding this abstract that shows an association between hyperuricemia and VTE, but the causal relationship has been unclear. So I think that kind of goes back to our lack of understanding thus far for the full physiologic functions of uric acid. Those are poorly understood still. And so there's this interesting, a relationship, I think, between the inflammatory pathway and coagulation activation that's been explored in the past, but not fully elucidated. And so these kinds of abstracts really, bring up this issue again and spark an interest in, again, highlighting the importance of treating hyperuricemia and gout, because this is yet another complication potentially of gout.
So, Dr. Khanna, does this surprise you? Is this novel? Is this interesting?
I think this is definitely thought-provoking, Michael, because we know that urate in itself is an inflammatory nidus. And over the past decade, maybe more, we have seen this renewed interest in the NLRP3 inflammasome mechanistic pathways of the MSU crystal. How does it incite that inflammatory cascade? I think this makes us think along the same lines of, is there an analogy? Is there some similarity that urate, that juxtaposition of urate being an antioxidant versus a pro-oxidant? What does it really do in certain situations where we have that perfect storm when there are other comorbidities such as, hyperlipidemia or poorly controlled diabetes, and the urate just tips you over? So I think this is really interesting and definitely needs a lot more work in the future.
I love what you pointed out about inflammation, because in some ways, if this data turns out to be true and reproduced, it's almost surprising that we haven't seen it before. We know that, inflammation in the setting of infection is really frequently accompanied by thrombosis, right? It's probably an evolutionary advantage to have a local thrombus. And when people are diffusely septic, they get, DIC. So why would an inflammatory state like gout not have at least some risk of that? Let's turn to another abstract now, this one by Eder and Leverens, which identified suboptimal urate lowering therapy in gout patients who had CKD. Do either of you have any thoughts on the challenges for managing gout in the CKD population? What are those gaps and how can we address them? Why are the CKD patients perhaps having at least as bad urate control as the rest of our patients? Would either of you like to take a stab at that?
Yeah, sure. I can start, Dr. Pillinger. Yeah, this was, interesting. I mean, I think across the board, whether or not patients have CKD, gout patients have CKD or not, we know that there's a huge lack of appropriate treatment, appropriate identification of these patients with gout. And so I don't think that the findings here were different than what we know of non-CKD patients, but definitely just highlights again the importance of filling those voids and bridging those gaps. And I think with our CKD patients, I'm not sure the reasons behind this. Unfortunately for these patients, there were actually often more than one reason. A quarter of these patients had more than one reason. Their uric acid wasn't checked at all in the span of a year. They were not on urate lowering therapy at all, or if they were on allopurinol, it was suboptimal dosing. So, I think there's a lack of education amongst our colleagues and probably with our nephrology colleagues as well. So first, we're not really appropriately following this treat to target paradigm effectively with our patients. So just being able to monitor a uric acid, which is so easy, is not being done. So obviously that's an issue. Also, this begs the question, is there a difference between how nephrologists and rheumatologists view hyperuricemia? And then lastly, I think with allopurinol, I wonder if the colleagues that are treating these patients are concerned about allopurinol toxicity, specifically severe cutaneous allergic reactions. Are they underdosing patients because of that fear? But I think that when we look at that data, with CKD patients and the severe cutaneous allergic reactions, it's kind of mixed. It's not that strong. So we probably are underdosing, undertreating, and not using the target that we know exists.
Yeah, I think that's really really an important point, Suneet. And of course, we know that there's a history of renal adjustments in the old days by Handy's metric that underdosed our patients. We also know at least some ways to reduce that risk of hypersensitivity that you mentioned. As you say, it's pretty rare, but we can get an HLA 5801 in high-risk patients and avoid allopurinol if need be, go to febuxostat or another agent. And we can increase stepwise and carefully, which is not the same as not advancing the therapy. They're really two different things. Puja, another thing I was thinking as I listened to Suneet present this is the fact that typically our CKD patients probably have higher urates on top of that to just make matters worse and probably need to be more aggressively titrated. Would you, not necessarily less carefully, but they may actually need more treatment to get to target. Would you agree or disagree with that?
I would definitely agree to that aspect. I think there is substantial amount of data out there that has shown, historically we've been actually hurt in terms of the Hande guidelines that, you want to use the lowest possible doses of allopurinol. But I think, Suneet, you raised a very important point that there are huge knowledge gaps for not only patients, but also clinicians. And the challenge with gout is what? It's only seen during an acute episodic flare-up. The patient never comes back because these flares don't occur often. So there's that missed window of opportunity for education and also feedback to the clinician as far as how to manage this disease aggressively. So I think that's one of the issues that were highlighted with the 2012 guidelines and also re-emphasized in the 2020 guidelines. And kind of this data is evidence for that, there, even in 2023, there continues to be suboptimal dosing of medications that exist.
So education, education, education. Let's move on to another abstract I think is really interesting and potentially very important. This one from Rodriguez Sosa et al., looking at a cross-sectional study of more than 190,000 Spanish patients who were hospitalized with gout over a 10-year period, looking at the comorbidities of the patients and the differences in comorbidities between men and women. Women have gotten short shrift in the studying their gout for a long time, and I think this is an important study. Suneet, could you share a little bit about this one for us, and we'll talk.
Yeah. No, so this was very interesting. And I think we definitely need more data like this as we become more educated on the gaps in treatment for gout. And looking at gender differences obviously will be very important there. I found the differences very interesting, although, to kind of share clinical experience, I actually hadn't really thought about whether there were differences between the genders or observed that necessarily in my patients. I think my battle locally has been identifying women first and foremost and actually diagnosing them. And so I think even despite knowing that post-menopause, the risk is equal between men and women for development of gout, I think many of us are still missing this as a diagnosis for inflammatory arthritis in women. And so I think for me, it really starts there with being able to educate colleagues on the fact that the risk is equal post-menopause. So we have to think about gout in women. And then, of course, taking it a step further and realizing that this is serious. We already worry about cardiovascular disease in our gout patients. And there's clearly some really significant comorbidities here associated with gout for women in particular.
Yeah, I think that's really important. And I think for our listeners, we love in the community to talk about causality. And, many of us are trying to identify causality because we have good gout drugs that if we could get people to use might reduce causality. But it isn't all about causality. It's also about prevalence and presentation. And I think it's really important to remember when you learn about comorbidities in a particular group of patients that if you're a clinician and a patient with gout walks through your door, you can talk about the relationship between their comorbidities all you want. But the first thing you need to know is they may be dealing with a set of issues and problems, and you should be ready to take care of them. Puja, do you have any thoughts?
Yeah, I mean, I think I'll second what Suneet said, that we often neglect the women in our practices when we think about the differential diagnosis of inflammatory arthritis, because we think of gout primarily as podagra. It involves the feet. We forget that it can involve any joint. It's a systemic disease. It can deposit itself in the joints, the urate. It can deposit itself in any organ system. And women tend to usually present with polyarthritis of the hands. And the first thing that, one thinks of is rheumatoid arthritis or erosive OA in the postmenopausal population. One rarely thinks, or one doesn't often think about gout. So I think that's a missed opportunity. And it would be important to remember that as part of your differential when you're seeing the patients in clinic. However, one of the challenges that I think our primary care colleagues often face is that they're dealing with multiple comorbidities in an older woman. So gout or inflammatory arthritis kind of takes, is lower on the totem pole and often gets missed. And that's why the referrals do not happen either, whether it comes to RA or gout. So I think, Suneet, your point is well taken that we miss the diagnosis because it's not on top of our differential.
Yeah, I think that's so important, right? Because so many of us, if the patient doesn't walk in with a swollen toe or a history of a swollen toe, will be very quick, especially in a female population, to just go, that's not gout. When in fact, in a female population, you need to be even more attentive, perhaps, than you would in a male population. Let's turn to a final abstract that I wanted to talk about. This is a study by Card-Gowers and Martyr et al., looking at modeling data, and it was presented at both EULAR and the ACR. This is about, we've been basically talking about aspects of burden of gout on our patients. This is a direct study of health and economic burden of patients who are controlled and uncontrolled in their gout. Of course, controlled and uncontrolled remains a little bit controversial, but be that as it may, in patients with CKD. So that's kind of a mouthful. And whenever I hear something as an economic study, I crawl under the desk. But maybe Dr. Grewal, you can do better than I can and not crawl under the desk. Could you help us out here?
Well, I will say, without getting into the details of this abstract, I think the key takeaways were really clear. The prevalence of gout is expected to rise over time. And probably the factors that are driving that increase are the population growth, aging, and all the things we've highlighted thus far, which is kind of lack of education, under-treating, underdiagnosing gout. So obviously all of that is, this perfect storm for why gout is on the rise. And unfortunately, as Dr. Khanna pointed out, sometimes we ignore gout unless it's flaring. And unfortunately, a lot of these patients who are flaring are going to end up in our emergency rooms, or have complications that are then going to cost the healthcare system, obviously, a lot more money in the long run. So I think it's very clear that gout prevalence is rising, the cost is rising, and we need to do more to control that and lower the cost, and take a preventative care approach here, like we have with other metabolic conditions like diabetes and heart disease.
Puja, any thoughts?
I think, we've had this data for a while, but we haven't had a look in a prospective manner. And more data is coming out from various parts of the globe as well, showing the rise in prevalence and incidence of gout as well. So I think there is a subtle paradigm shift that is occurring slowly but steadily across the nations, and there is more recognition of gout as a systemic disease. And, this actually makes it easy to make our point clear with the policymakers that, hey, you know what, you want to invest in the gout patients because they do need early, identification, early diagnosis, and aggressive management of disease.
Couldn't agree more. Listening to you two talk brought to mind a couple of studies by Mark Fisher when he was at Mass General. Giving Mark a shout out because he was my fellow once. One of them published only in abstract form. I think the other was published. In the first one, it turned out that a hospitalized patient who develops a gout attack, which is not that unusual, as you know, actually increases the duration of stay by an average of 5 days. So just do the math on what it costs for a hospital bed nowadays. I'd much rather go to the plaza and save my money. It's a lot cheaper. And the other is work that Mark did with Yan Choi, who's the major gout epidemiologist at Mass General, looking at the mortality burden of gout. So we haven't talked about it, but there are numerous studies that simply defining a patient as having gout indicates they have an increased mortality over time, whether because of the crystals or the comorbidities, a little bit hard to say. But what the study showed was that whereas the mortality associated with rheumatoid arthritis has fallen over the years, the mortality associated with gout has not budged. And of course, the prevalence of gout is 2 to 4 times higher than the prevalence of rheumatoid arthritis. So gout really is a disease that I think needs to be, taken seriously. I would just say that we've spent the last few minutes talking about some studies looking at aspects of the burden of gout, either from a clinical point of view or a population point of view, or even an economic point of view. And I think we've underlined that this is a disease to be taken seriously. I'd like to thank Dr. Khanna and Dr. Grewal for joining me in this podcast, and I want to thank all of you in the audience. We look forward to listening and working with you in future podcasts as well. Thank you very much.
Thank you for listening to MedEd Talks Rheumatology. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Uncontrolled Gout, comprehensive updates on the latest management strategies.